Okay, good afternoon again, and we're going to continue with the surgical session. And I'm going to share the stage and my Professor Gürsükyan from Marmara University, Istanbul. And I suggest that most of you know him because he's one of the pioneers of pediatric thoracic surgery in Turkey. And it's a great pleasure and honor for me to share the stage. In this session, we have three experts from Tunisia, Germany, and United States. Firstly, I would like to introduce Dr. Amin Sia from Tunisian Association of Pediatric Surgery. He is working in Fatouma Bourgaba Teaching Hospital in Monastir, and he also worked in Armand Tussaud Hospital in Beatrice in Paris. And also he has worked as a consultant pediatric surgeon in Saudi Arabia. He is currently board member of many scientific associations, including the IPAC Middle East chapter, and he has numerous papers in the literature regarding with the esophageal pathologies in children. In addition to his expertise in pediatric surgery, he's a very good friend of us, and he's an excellent teamwork, and he's a very good member of PAAFIS, and I would like to introduce him. His topic is about the difficult esophageal strictures and stents versus replacement surgery. Dr. Sia?
Many thanks, Tutku, for the kind introduction. I will just share my screen. Is it okay? Do you see my screen?
Yes, we see your screen.
Thank you very much.
Great.
Dear friends and colleagues, this is my pleasure and honor to be part of this big event, the PAAFIS 22 web meeting. For this, I should thank very much my dear friend, Dr. Tutku Soyer, for the kind invitation, and also thank all the PAAFIS office. Personally, I attended for the first time the PAAFIS meeting in 2017 when my friend Oliver Monsterer organized it in Mainz, and was really impressed by the outstanding presentation, the wonderful workshops. But more than this, I was impressed by the friendly atmosphere that you can feel between all the members. So now I feel very proud to be part of this family, the PAAFIS family. Tutku asked me to speak about difficult esophageal stricture in children, stents versus replacement. As you know, esophageal stricture are defined as abnormal narrowing of the esophagus lumen due to different underlying etiologies. Most of the strictures can be managed by simple dilation, but sometimes we can face difficult cases that are real challenging situations. Here in this presentation, we will try to follow this plan. First of all, we will try to define what is a simple, what is a difficult esophageal stricture. After, we will describe esophageal replacement and esophageal stenting as possible tools to heal this difficult esophageal stricture, and we will finally make our conclusions. Let's begin by our first part. What is a simple, what is a difficult esophageal stricture? A simple esophageal stricture is a short, focal, straight stricture that allows the passage of a normal diameter endoscope. And here in this case, 1 to 3 dilations should be sufficient to heal this kind of stricture. Regarding difficult stricture, here we will have long, irregular, ungulated stricture with severely narrowed diameter. And this kind of stricture are refractory to simple dilation. And you can imagine that this difficult stricture will expose the patient to severe complications like the failure to thrive, the aspiration danger, and will need numerous dilation and numerous general anesthesia with unguaranteed results. Regarding the possible etiologies of this difficult esophageal stricture, it can be anastomotic, peptic, but the most frequent etiology in children is caustic stricture. It's true that we are observing less cases of difficult stricture because there are many efforts that are done on the prevention of this kind of stricture. For example, for peptic stricture, we are having more efficient medical treatment and also more efficient anti-reflux surgery treatment. And also for caustic stricture, there are many laws that are banning the use of this corrosive product, but still we are observing these cases, and particularly caustic esophagitis, because caustic esophagitis is like a progressive disease with unpredictable issue. That's why for this difficult stricture, sometimes we should manage with other options than simple dilation. And these options can be, first of all, the esophageal replacement, but also many teams are proposing also esophageal stenting as a possible solution for these cases. Let's begin by the first solution, the esophageal replacement. Certainly, esophageal replacement can save your patient and give him a better quality of life, but you should prepare your patient. This patient should be managed in experienced centers, and you must know that this kind of surgery are big surgeries, so we can have severe complications that some can lead to mortality. The other issue in esophageal replacement is the fact that we will not conserve the native esophagus, so many questions can be raised regarding the functional outcome. The other problem in esophageal replacement is the controversial points. And here we have two main controversial points. First of all, the best conduit that we can use, and also the best route that we can use for this conduit. Let's begin by the first controversial point. So you must know that despite being a non-vital organ, a well-functioning esophagus can be shown to be very essential for the human well-being. And for children, the esophageal replacement conduit should be long-lasting, this is mandatory, with minimal reflux, should not affect the cardiac and pulmonary function, and should allow normal oral nutrition. Whatever the conduit you will choose, you must prepare your patient. You must prepare your patient regarding nutrition condition, regarding the gastrointestinal tract that you will use, regarding the respiratory system, all this in order to have safe anesthesia and a successful surgery. Now, what are the options for the organs that we can use to replace the esophagus? We can use four organs for replacement of the esophagus. First of all, the jejunum that was used for the first time in 1907 for the adults by Dr. Roux in Lausanne. Also, we have the colon that was used in 1911 for adults, and colon is the first organ used in children in 1950. And also you can use the stomach in two manners, by first of all, the confection of a tube or the transposition of the stomach. Now we'll try to describe briefly this technique and to collect the advantages and disadvantages of each technique. Let's begin by the gastric transposition. In gastric transposition, we will pull up the stomach in the chest. This is a simple technique because you will perform only one anastomosis, but the main problem with the stomach is the volume of the stomach that can compromise the pulmonary function and the cardiac function. For the colonic graft, here the volume of the colon is suitable. The main problem is that this surgery is complex, as we will perform at least 3 anastomoses. The other problem is the risk of redundancy and tortuosity, and also the slow food transit. We can also use the gastric tube. Here also the volume is suitable, but the main problem is the long line of sutures that we must perform. So you can imagine that we can have a higher risk of leakage. And finally, the jejunum. You can use the jejunum as a graft for esophageal replacement. The size of the jejunum is just perfect. It's like the esophagus. The main problem is that this surgery is very complex with at least 3 anastomoses, and also the very precarious blood supply. And if you have a very precarious blood supply, we can have a higher risk of leakage and of stenosis. So we'll try to summarize this important part in this table. So for gastric transposition, the main advantages are a simple surgical technique, the adequate graft length, the excellent blood supply, the need for 1 anastomosis only, but the disadvantages are the volume of the stomach, the high risk of reflux, and also the delayed gastric emptying. For colonic interposition, here the advantages are adequate graft length. The graft occupies little space in chest and there's a low risk of reflux. The disadvantages are the precarious blood supply, the need for 3 anastomosis, the high risk of anastomotic leak, the high risk of tortuosity and redundancy, and the slow food transit. For the third option, gastric tube reconstruction, the advantages here are the adequate graft length, the good blood supply, the rapid food transit. The disadvantages are the long suture line, the continued production of acid by the tube and the risk of Barrett, and the high risk of leaks and stricture. And finally, for general interposition, the advantages here are a graft diameter similar to the esophagus, the graft occupies little space in the chest, and the graft peristaltic activity that is good. The disadvantages are complex surgical technique, the extremely precarious blood, and also the fragility of this jejunum to the acidity, and also the need for 3 anastomosis. Here, perhaps I will disappoint you, but I cannot tell you what is the best graft that must be used. And I think that nobody will respond you what is the best graft that must be used. I can just tell you that colonic interposition seems to be more popular. This is according to many surveys and also according to the literature. I just exposed you this opinion for this author who is quietly reasonable. The colon is the most preferred and safest organ for esophageal replacement. Stomach is a vascular and muscular organ with lower risk of ischemia, and the gastric tube is a demanding technique, and jejunum and ileum can be a good alternative for redo cases. Now we will move to the second controversial point, which is the route of this graft. So we have now 2 main routes that we can use. The retrosternal route, here the technique is simple. We have a short route, but there's more risk of kinking, obstruction and of pneumothorax. And we can also use the mediastinum, which is the natural route of the esophagus. Here there is less risk of kicking, but it's more difficult, more risky. You see all the vessels that we have in the posterior part. And here we should remove the native esophagus. So whatever the route that we will have, whatever the graft that we will use, we must ask us about the functional outcome and the long term of this graft. And here we have, or we notice some contradiction between the paper's conclusion and the reality. Most of the surgeons will tell you that their patients are doing well and they are living normal. But in reality, those who are now adults certainly lead normal lives, but nevertheless, many children experience noisy breathing and coughing reflexes, and also have acquired adaptive eating habits such as drinking between each bite. So this means that their life is not really normal. And also there are many questions that are raised regarding the malignancy risk. I'm not talking about the remaining esophagus, but also about the grafts. So it's possible to have this question about this malignancy risk about the grafts. If you add to this the fact that this is a big surgery with possible complications, so that's why some teams are proposing another option, that is the esophageal stenting. Why we are proposing esophageal stenting? Because in esophageal stenting we will use self-expandable device, which means that we'll have like a permanent dilation that can be more efficient. And this can be a good alternative to recurrent dilation and to esophageal replacement. But you must know that this is a demanding technique, and the most perhaps difficult thing in esophageal stenting is how to choose the appropriate stent. Because we have different types of stents with different materials, different designs, different luminal diameter, and different radial force that is exerted, and different rate of flexibility. Here I will describe 3 types of stents that we are using in Monastir, Tunisia. First of all, self-expandable polyflex stent that are the only plastic stent commercially available. The top of the stent here is flared in an effort to reduce the migration rate. And this kind of stents are extensively used in the treatment of benign condition. The problem with the stent is that we will need general anesthesia to put the stent, and we will need also general anesthesia to take off the stent. That's why engineers have created this biodegradable stents. Here, the stent integrity and radial force will remain for 6 to 8 weeks, and the stent degradation will occur after 12 weeks. And we don't need here a removal procedure. The issues are the cost and the experience. Finally, we can use this fully covered tracheobronchial stent that is manufactured to be deployed in the tracheobronchial tree. Here we have a smaller diameter, so it can be suitable for pediatric population. Whatever the stent that you will choose, there are some rules that are mandatory for the success of your technique. And these rules are the right stent should be at least 2 millimeters larger than estimated lumen or least dilation, should be 4 centimeters longer than the stricture, and it should be placed at least 1 to 2 centimeters above and below the stricture being treated. So you understand that here we do need a careful study of the esophagogram. Regarding the procedure is done under general anesthesia. We use endoscopy and fluoroscopy. We'll perform prior endoscopic balloon dilation, and after we'll put a guide wire, and after we will put our stent. And here we must follow the steps that is noticed for each stent, because they are different between the stents that are manufactured. And after, we must be sure that the stent is well putted by endoscopy, and also we must check that there is no esophageal leak by injecting water-soluble contrast material, and we must have an available forceps if we need to remove this stent. In Monastir, we have a protocol after putting the stent with fluid diet, corticotherapy protocol, anti-reflux regimen, and also, this is important, we must confirm appropriate stent position by performing chest radiograph like this. So you see that the stent is 1 to 2 centimeters above and below the stricture. You must know that in this technique, you can observe some complications. You can have immediate complications like technical failure, aspiration, airway compromise, malposition, stent dislodgement, and perforation. We can have early complications like bleeding, chest pain, and nausea, and we can have late complications like recurrent dysphagia. Migration, this is really the main complication that we are observing, tracheoesophageal fistula. We can have also bleeding and aspiration. So here we will try to describe our experience. We attempted this technique for 19 patients. The main causes of stricture were caustic in 18 cases, and only 1 case anastomotic stricture. The average time of the procedure was 40 minutes. We had 1 case of perforation and 8 cases of migration, which required the stent to be removed or reset. So migration is clearly most frequent complication of this procedure. We see in this X-ray the migration of the stent, and here we performed an endoscopy to remove the stent. We see this complication in approximately 40% of the cases, mostly for covered little stent and thus put it in the upper esophagus. For our final results, for our 19 patients, 3 children needed esophageal replacement and 4 children need further dilation, and probably we need esophageal replacement. So we will finish by our conclusion. I think that we must now view these 2 tools as controversial tools. It's not a competition between them, but they must be like a complementarity between these 2 tools. In fact, I think regarding this difficult esophageal stricture, you must study each field. Each patient is particular. For example, you see in this example, the esophagus is really damaged. And here we must consider esophageal replacement as our first option. For cases like this, here we can attempt dilation or stenting. For example, in this case, stenting was very efficient for this patient and healed this patient, or esophageal replacement if there is no success. And in another way, we can also consider stenting as possible bridge to esophageal replacement. It can be like a preparation for your patient, because when you put your stent, this patient can conserve the possibility to eat using his mouth, and this is very important. He can gain weight, you can prevent the aspiration danger, and your patient can be operated in better condition. I will conclude by saying some words about the future. First of all, I think for esophageal stenting, the results will be better because probably in the future we will have better devices. Also for esophageal replacement, I think that the results can be better by having a better tissue, and perhaps tissue engineering will be the solution. But the best solution for this patient is the prevention. The best thing that can occur for the surgeon is to not see this kind of patient and to not have to treat this kind of patient, because they are very challenging situation. So I finished it. I want to invite all to visit Tunisia. Perhaps we will have a PAAFIS activity in the future, and I hope that your first destination after this COVID pandemic would be Tunisia. And I will be very happy if you will have a question and to respond to your emails. Thank you very much for your attention.
Yes. Thank you, Amin, for your nice presentation, and I really enjoyed. And for the audience, we are still receive some questions from the audience, and please, if you have any questions to the presenters, write it down, and we can see and we can just ask them. Up to now, we have one question from another faculty member, from Thomas Srega, and he asked a question. As I understand, you mostly do colonic interpositions. I'm right? Okay.
Yes.
And both mine and Tom's question is that, do you perform or do you recommend routine colonic endoscopy for the patients who you have performed colonic interposition for colonic cancer or any other disease like the colonic polyps, or when they become adults? Do you have a routine endoscopic surveillance for those patients?
No, actually, we don't have a routine endoscopic check. We do it if there is any problem, but it's not routine check.
Okay. I think no more questions, and maybe we can move to our other speaker, Professor Kian. Professor Kian, please, microphone.
Sorry. Our next speaker in this surgical session is Professor Oliver Münsterer. He is for the time being the Chief of Department of Pediatric Surgery in Johannes Gutenberg, University of Mainz. But soon he will be starting as the Chief of Department of Pediatric Surgery at the Dr. von Hauner Children's Hospital of the University of Munich. Congratulations once again. He is the founding president of PAAFIS, and I have to admit that he tried so hard for establishing of PAAFIS. Today, Professor Münsterer will talk about laparoscopic treatment of hiatal hernia in children. Oliver, please, the virtual stage is yours.
Thank you so much, Gersu. And do you guys see my presentation and hear me well?
Yes, okay.
Excellent. Okay. Yeah, thanks so much. I really enjoyed this. I must say, excellent talks so far. Really learned something also in the first session, and especially with Amina's presentation with the fence. That's an important topic. So what I was asked to do is talk about the laparoscopic treatment of hiatal hernia in children. And this is something that compared to adults is actually not that frequent. It basically, there's several possibilities here. One would be having a hiatal hernia from birth, so a congenital one. Those are very rare. And of course, we do see this once in a while after surgery, especially after fundoplication, where they will recur and then you'll have a hiatal hernia that you have to deal with. So this is the normal situation, as everybody knows, and we have a little bit of intra-abdominal esophagus. We have a nice His angle because the esophagus connects to the stomach in an angle. And these are the anti-reflux mechanisms that keep you from getting gastroesophageal reflux. Now, how does it look in a hiatal hernia? Basically, hiatal hernia means that the stomach is being pushed up or is translocated into the chest, part of the stomach at least. And so there are certain types. The type 1 is a sliding or axial hiatal hernia, which you can see here. And as you see, I mean, there's no intra-abdominal esophagus. There's absolutely no His angle anymore. And this is extremely prone to gastroesophageal reflux. So people that have this type of hiatal hernia are very, very prone to having gastroesophageal reflux and suffering from it. So that's what you need to know. Now, the type 2, I don't have a picture of it, but type 2 is a paraesophageal hernia. That means the angle or the His angle is intact. The esophagus connects to the stomach below the diaphragm, but a part of the stomach has herniated along the tract of the esophagus, along the esophageal hiatus into the chest. That would be a type 2 hernia. Typically, these are asymptomatic because they are not frequently associated with gastroesophageal reflux disease. Type 3 hernias are kind of a combination of the two first ones. So you have an axial hernia where the junction of the esophagus and the stomach are in the chest, but you also have this paraesophageal component of that herniates up into the chest. And then finally, type 4 are hernias where other tissues are herniated into the chest as well, or the entire stomach is herniated into the chest. If you have this situation, these are patients that are at risk for developing something called the gastric volvulus, which can be life-threatening. So if you have this type of situation with an upside-down stomach or a stomach in the chest, then these need to be addressed pretty quickly, depending. If they're volvulized, if the blood supply is compromised, of course, it's an emergency. Otherwise, they should be dealt with in an urgent basis. So as I said before, you can have this kind of anomaly from a congenital standpoint, but you can also have it because of acquired issues. Mostly in children, this is after fundoplication, but it can have other issues as well, or other reasons as well. So there's a lot of questions regarding hiatal hernia. For example, what is the incidence? What is the incidence in adults? And what is the incidence in children? And we'll see that is markedly different. What are the symptoms? I can tell you the symptoms are mostly gastroesophageal reflux, but there are other symptoms. Should it be treated? If so, when and how? We already touched a little bit on that with the gastric volvulus and the type 4 hernia. What technical considerations are warranted if you do this? What kind of outcome can we expect? And what are the special considerations in children? And finally, if we do this type of surgery, how can we decrease the risk of post-operative hiatal hernia, especially after fundoplication, since this is the most common reason for children to get it. So generally the risk factors, and this is from adults and kids together, are advanced age. So of course this plays into a role in adults. obesity, which also, again, mainly is associated with hiatal hernias in adults. Trauma. So if you have a trauma and an increased intra-abdominal pressure, that can actually cause a hiatal hernia. And that can be true for children and adults as well. Finally, we see hiatal hernias with certain chromosomal anomalies in children. So these are usually the congenital types, syndromes, and especially heterotaxia and dextrocardia. So if you have a child with congenital heart defect and they have heterotaxia, then this is something that you should be aware of and have in the back of your mind. And finally, as I said previously, prior surgery, and especially in the form of fundoplication, is a risk factor for developing a hiatal hernia. So what is the incidence? In adults, it's pretty clear. We have good numbers. So actually, 60% of individuals aged 50 or over will have a hiatal hernia. So this is something very, very, very common. But only about 1/10 are symptomatic in the adults. And most of them are type 1 sliding hiatal hernias. So unfortunately, there's no epidemiologic data in children. Congenital hiatal hernias, I've only seen like 3 true ones in my life, the ones that have no other issues and present with a hiatal hernia. And I'll show you an example when we get to it. The congenital traumatic hiatal hernias are probably different in etiology than the standard adult type hernia that happens in people over 50. So how can we diagnose it? Well, if you're a very good radiologist or you have a very good radiologist, actually your chest x-ray can give you some clues. So if there's a large bubble or a mass behind the heart, then that might be a sign of a hiatal hernia. It's much easier to see if you give contrast media. So if you have them swallow something, as you can see here, you can see that 1/3 of the stomach is in the chest, and that's just easy to see because your landmarks are there. You have the diaphragm, you have the ribs, and so forth, and you know where around your gastroesophageal junction should be. And in this, you can see that it's markedly above the diaphragm. A CT is usually used for complex cases in adults. It should not be used in children if you don't need to because of the radiation exposure. What about endoscopy? This is an example of a typical hiatal hernia. This is something that's that you can do fairly easy. You might need sedation or even anesthesia, but you can see this. So here you can see the gastroesophageal junction where the scope comes out. We're inverting the scope and looking up, but you do see that the gastroesophageal junction is above this big, let's see here, I don't know if you see my arrow, but this part of the stomach that is herniated into the chest through the diaphragm. So pH probe, of course, can measure reflux, and reflux again can be an indication that the patient may have a hiatal hernia as the basis for their problem. And finally, we can do manometry, and this is actually a very good test to test for a hiatal hernia because you will see the lower esophageal sphincter above the diaphragm, and that will give you the clue that there's a hiatal hernia. So what should we do with all this? Now, a couple of years ago, I was involved in a project by the SAGES guideline committee. And we wrote a guideline for the management of hiatal hernia. And as you can imagine, I was the guy that sort of did the pediatrics part of it. So I'll just go through the guideline as, some of the things. What are the indications for hiatal hernia repair? So repair of a type 1 hiatal hernia in the absence of reflux is not necessary. It's just so so frequent. You would have to, operate almost more than every second adult if they're over 50. It's just not worth it. And it doesn't need to be done, because if they're fine, they don't have symptoms, you can leave them alone. And remember, only about 1/10 of the patients have symptoms. Symptomatic paraesophageal hiatal hernias should be repaired, particularly those with acute obstructive symptoms or volvulus. Like I said, if you have the stomach in the chest or so, you should be aware that this can twist and compromise blood supply. So they should be operated on. Routine elective repair of completely asymptomatic paraesophageal hernias may not always be indicated. Consider age and comorbidity. So it depends a little bit. If the patients are very old, then they would not recommend it, or if they have other comorbidities where the anesthesia is more of a risk than the possible benefit. And like I said before, acute gastric volvulus requires reduction of the stomach with limited resection if needed, if there is compromised blood supply and necrosis. But this needs to be dealt with on an emergency basis. This is really the only emergency in this talk. So what about the kids? So the same thing. Hiatal hernias that are symptomatic should be repaired, and the others you have to sort of, weigh a lot of different information. And what we found is also a laparoscopic approach to children is feasible. So you can do this laparoscopically, and agent size should not be an upfront contraindication to laparoscopy. So we've done this in very young kids under 1 year of age, and only a few months of age for that matter, and I'll show you one. And of course, there's no upper age limit. What about the pediatric technique? So gastroesophageal reflux in pediatric patients with hiatal hernia should be addressed by a concomitant anti-reflux procedure. There is a little bit of debate in the literature on this. So some people think that a hiatal hernia is a pure anatomic anomaly that you can fix in an isolated form. However, most of us and most authors recommend doing an anti-reflux procedure at the same time, because these children usually present with reflux. So you're operating on them for a reflux. They're already under anesthesia, and you don't know if they still have the reflux if you just do the hiatal hernia repair. There is indication that there's a high likelihood that lots of these kids do, and therefore an anti-reflux procedure, at least in my mind, is indicated. Standard of care in children is excision of the hernia sac or disconnection of the sac from the crura. You have to do that. If you do not take the sac out, it will recur. To lower the risk of postoperative paraesophageal hernia after fundoplication, these are the typical kids that have a hiatal hernia after fundoplication. In the pediatric population, you should do a minimal dissection of the hiatus, not a maximal dissection. I'll show you a picture of that. And finally, plication of the esophagus to the crura may decrease recurrence in children. So, doing so-called collar stitches. I'll show you what I mean. Postoperative nausea and vomiting should be treated aggressively to minimize poor outcome. This applies to both adults and pediatrics. And you may be aware that one of the highest factors, or the factors that is most highly associated with failure of fundoplication is postoperative retching and gagging in these kids. And we believe that has to do with the intra-abdominal pressure that is produced when you gag or when you retch, and also the intrastomach pressure that is placed on the fundoplication. So that probably leads to failure. And unfortunately, at least in children, there are no good medications to treat retching. This is a behavioral issue, and it's really hard to treat. The only thing that I can say is if you happen to have a gastrostomy tube at the same time for some reason or another, then opening it up when the kids start retching can help. Revisional surgery, if you have to do this, you can do it laparoscopically if you're an experienced surgeon. And I want to show you a little, this is one of the patients that I operated on. And he was only 2 months old, and he had a lot of difficulties feeding. Otherwise, he was completely normal. No heart disease, no syndromes, and so on. And this is what it looked like, his swallow study. So he has at least type 1, if not type 3, hiatal hernia. So what are your operative goals? There's like a little review article in Seminars in Pediatric Surgery, and they place 4 goals. Reduce the hernia contents into the abdomen, close the crura, possibly perform collar stitches that I'm going to show you in a moment, perform an anti-reflux procedure. So those are the 4 pillars of hiatal hernia repair, according to Garvey and Ostley. So this is our patient, our 2-month-old patient, and what he looked like. And you can see that the hiatus is huge, and a lot of the stomach has herniated into the chest. It all looks well perfused, it all looks fine, but there's a large hernia. Now, the first thing that you have to do is reduce the stomach into the abdomen, like so. So this is now the stomach that is pulled into the abdomen, and you can see that there are a lot of bands, and the sac is visible where the esophagophrenic ligaments are in the background. So you take down all of these bands, and you do have to resect the sac, as you can see here. This is the dissection of the sac. And once that is the case, you can fully reduce the stomach into the chest. Now you can see this, the esophagus on top on the upper right corner and the stomach on the lower left corner. You can see how you can pull it down. And then here you see us perform these collar stitches. So you actually tack the diaphragm to the esophagus in certain places, as well as the crura here in the back. So that is shown to decrease recurrence. And if you for the younger ones this is the vagus nerve, the anterior vagus nerve, that you see very nicely here. That's why I think this kind of surgery should be done laparoscopically, because you really have the overview and you have magnification, and you can see the structures very well. You can perform a very good operation. There is when we were doing these guidelines, we were talking about mesh. Now in adults, putting a mesh there has pretty much become standard of care. However, in kids, there's very little information. And so there are a few studies that have looked at that, and there's a few instances where the mesh has actually migrated into the esophagus or caused an erosion of the stomach, of the esophagus. And what we said in our guidelines, because there are multiple case reports of that happening, this erosion, that we at that time did not recommend using mesh in children, much to the difference of the experience in adults. And finally, this is what that paper in Seminars talked about. In the end, we performed Nissen fundoplication as a reflex procedure, anti-reflex procedure. So what's the outcome? So there is a study that looked retrospectively at the patients after laparoscopic congenital paraesophageal hernia repair, and they followed 28 patients who underwent 30 procedures, and just from the numbers, you can figure out that 2 patients had recurrences. 6 were type 2, 16 were type 3, and 6 were type 4. So 2 recurrences were repaired laparoscopically. There were no deaths. There was 1 thorax that required a pigtail drain. And the authors of this studies, although it's a retrospective studies, claim that laparoscopic hiatal hernia repair is safe and effective, and you can help the patient in most cases. So this is what we talked about. How can you prevent a hiatal hernia when you do a fundoplication? And the answer is, at least in children, is minimal dissection. So this is actually the second, the first study that was done was from 2007, also by Sean St. Peter. And they randomized their kids to maximal and minimal dissection. So in the minimal dissection shown here above, you do not take down the esophagocrural or esophageal phrenic ligaments. You leave them intact. In the maximal dissection, you take everything apart and then you put it back together again. So they randomized 170 patients, 87 in the maximum dissection group, 90 in the minimum dissection group. And their transmigration rate 1 year post-op was 30% in the maximal group and only 8% in the minimal group. And this was highly significant. So their conclusion was, if you do a fundoplication in children, do not do maximal dissection. Actually spare that. And I do that all the time. Why? It's better from the studies, but it's also much easier. You don't have to take down what nature has given the patient. So just leave it intact. You'll have, you'll be faster. You'll be, it's going to be an easier operation, and it's going to be the better operation for the patients. So the other question that Sean St. Peter, he does all these studies, this is his thing, answered with this study is, should we do an esophagocrural sutures? Should we do this in the fundoplication? I'm not talking about hiatal hernia repair. I'm talking about fundoplication alone to prevent later hiatal hernia repair. So he did a randomized controlled trial as well in 120 patients, in which 52 underwent esophagocrural sutures at the time of fundoplication, and 54 did not. And this is what they found. Transmigration rates at 4 years post-op, no difference, absolutely no difference. So it's totally up to you. You don't have to do them, but it's not wrong to do them, and you don't change the outcome at all. So that's my take-home message. Hiatal hernias in children is much less frequent than in adults. Should repair it if symptomatic or risk for volvulus. Laparoscopic repair is feasible and safe, and minimal dissection during fundoplication reduces postoperative hiatal hernia rate, but the crural stitch does not. Thanks so much, and I'm happy to take your questions. And I'm really looking forward to seeing you all in Ankara in 2021. And I really hope that they develop a vaccine soon. Actually, down the street from here is one of the companies that's working on the vaccines, and they say it's promising. So hopefully that'll happen soon. Thanks.
Okay, thank you, Oliver, for your didactic presentation, and I enjoyed it very much. And there are no questions. I have 2 questions for you. For paraesophageal hernia, except excision, complete excision of the sac, do you go for extra maneuvers in paraesophageal hernia surgery to prevent recurrence if compared to standard reflux surgery?
So that's a very good question. So if it's a type 1 hernia, an axial hernia, I would do a fundoplication. In the true paraesophageal hernias, I usually mobilize the stomach, pull it down, I will then fix the hiatal hernia and close it. not too tight, not too open, and then I will see. And if there is a good His angle and you have adequate amount of intraesophageal length, I will just leave it intact, like leave it the way it is. If not, then I would perform fundoplication. But you can just pull it down and just fix the hiatal hernia, and that has actually, I've had a good experience with that.
And second question is, one thing is still not clear for me. Should we operate all the paraesophageal hernia patients if they are even if they are not symptomatic?
So in children, there are no guidelines. Yeah, there's no information on that. In adults, they would, except for if there's any contraindications such as age or other comorbidities. In children, I do not think that we need to do that. If they're completely asymptomatic, I don't see a reason.
There are some reports in the literature with some ischemic problems for the stomach.
Obviously, then you have to do it.
Okay, thank you. And our last speaker.
Sorry, Dr. Gürsu, we have questions from the audience. Did you check them? Do we have time?
Oh, yeah.
Also, one question from Chidem, but she directly wrote me. If you give me permission, I'm going to ask the question to Oliver. Yeah, the question is, do all the hiatal hernias developing after fundoplication need to be repaired?
Good question. There's no data on this, and I would say it's the same as we just discussed. If it's an asymptomatic hernia and the kid's doing fine, I would not go in and I would not touch it. If the kid has symptoms, I think they should be repaired.
And there are two more questions. The first is the NG tube post-op necessary?
It's a good question. It probably is not necessary. I don't use it, but if you have a child with neurologic deficits and they are retching, then you can decompress the stomach with it. So it might be a good adjunct tool in those cases. If they're not neurologically impaired, I think I would not leave it in G.
And the last question is, if you do a fundo and you consider the hiatus is white, then you do collar stitches as well?
So I would, my personal algorithm is, if there's no hiatal hernia, I leave the entire hiatus intact. I do not take down anything. I do minimal dissection. If there is if I find a hiatal hernia, then I will do a full mobilization, and then I would do collar stitches. And then, I usually close the posterior hiatus. And if the hiatus is so big that just one or two sutures in the back won't close them, then I also use an anterior stitch.
Okay, thank you very much, Oliver, once again. And our last speaker of the day is Reza Zarniger. He is a general surgeon, and he's professor of surgery and works in Department of Surgery, Division of Endocrine and Minimally Invasive Surgery in Weill Cornell Medical Center in New York, again. And he's also director of robotic surgery. His today's presentation is about redo fundoplication, which is a troubled issue also in pediatric age group. Reza, please.
I'm going to unmute. Thanks for having me. I really appreciate being here. I'm going to share my screen and go to presentation view. So, I just wanted to, thank you guys for having me here. I do a lot of foregut surgery at Weill Cornell. I've been doing it for over 12 years. And we may have a discussion with Oliver about this in a bit, but I'm going to go completely the opposite direction of what Oliver talked about as far as extensive dissection and what's the most important part. And I'll show you some evidence of why I think that's the way in adults anyway, and I think it should be explored further in children. I've been at Cornell. You guys are, once this whole epidemic is over, New York City is a beautiful place, and we'd more than love to have you here. This is the hospital that I'm at, and I've focused on foregut for a lot of years and published extensively on it, and also on technology in relation to foregut. So what I want to sort of talk to you about briefly as we progress through this is looking at some technology to rationalize why we do surgery the way we do it. I actually do a lot of robotics. I know that back when Dr. Munster was here, we did a robotic Nissen, I think, on a 5-year-old or something, and that was definitely fun. I do think the instruments need to get smaller, but I think it does have definite advantages in reoperative surgery and in adult primary surgeries. I know he also talks about mesh technology in children. I think now in adults it's becoming more common again. And also, as opposed to in children where, you know, we are trying to limit the dissection, in adults we're doing now more relaxing incisions and colluses or lengthening procedures, which I think become fundamental when you do reoperative surgery also. In adults, I think everyone's sort of seen the outcome of reflux surgery when Nissen came out with his publications back in the 1950s, and soon after, it was amazing. The reflux surgery in adults was thought to be the cure-all for an issue that a lot of people suffered with. And then 10-year data came out, and it was still not bad. But if you look at the data, at 10 years, most people are still off medications, but about 30% are back on medication. So if you think about it, your failure rate with reflux surgery, I think, is still high. Now, if you talk to a lot of gastroenterologists in adult populations, they think that rate is even higher. And that's part of the problem. Now, there's a common concept of why in adults reflux surgery fails. A lot of people will present, and this was a study done in Annals of Surgery in 2005. A lot of patients present with problems swallowing. They re-present with reflux and paraesophageal hernias. And interesting enough, a lot of times it's not because there was a disruption in the wrap. It wasn't because your wrap became from a Nissen 360 to more like a Toupet 270 or so on and so forth. That was less common. The most common reason was because your wrap actually re-herniated into the chest. So unlike in pediatrics, the most common reason for reoperative surgery in adults is, 47 to 61% of people will have recurrence of herniation. And that's a big problem and an issue with these patients. There was another interesting study that came out of Italy back in 2009 where they actually looked at hiatal hernias in adult populations. And somehow, I don't know how they got away with this, but they biopsied the diaphragms of people that were undergoing gallbladder surgery and compared to the people that were having hiatal hernias and reflux. And they looked at it under electron microscopy is what you see here. And this is the normal architecture of what a diaphragm will look like. What they found in a lot of adults with reflux was that normal pattern was disrupted. So a lot of the ultrastructure of the diaphragm in patients with hiatal hernias in 94% of patients was weakened. So the theory is that most of the patients that present with hiatal hernias have a weaker diaphragm and therefore have a higher risk of reherniation, mostly because of this. Now, I want to sort of talk to you about EndoFlip. I don't know if anyone uses it, and we can discuss it more later on, but it's a kind of a novel technology that we'll be talking about. I also will talk to you briefly about mesh technology, relaxing incisions and colluses. But this is a study we just published actually in Annals this year. This is a study looking basically at what affects EGJ compliance during reflux surgery, and what's the role of the hiatal hernia closure versus the fundoplication in these cases. Now, if you look at the pathophysiology of reflux, there's a lot of different components, but the major components are the intrinsic LES pressure. There's also the external pressure based on the diaphragm causing external pressures, and also, of course, the sling fibers that create the flap valve that prevents reflux. Of course, there's other things in adults that cause reflux, including smoking, obesity, and so on and so forth. But mechanistically, it's mostly those three structures. EndoFlip is a technology that actually looks at the LES in a three-dimensional aspect. So this is sort of what an LES looks like on the left, and what you see here is kind of the structure of the thinning out of the basically the flip balloon going through the LES. And sort of you can see that this is sort of the length of the sphincter augmentation that's happening. Here we're in the stomach and this is in the esophagus. And what they've noticed, and Pandolfini and a lot of other people have published on this, is compliance of the LES, or how loose it is, will lead to reflux. And EndoFlip looks at compliance using distensibility, how wide the balloon distends. And basically what they found out is if you have an increased compliance, so the balloon is wider, so it becomes more yellow, there's more odds of reflux. There's also other things that come into effect, which is cross-sectional area and length of the sphincter, which is kind of the blue area on the graph. Now, this is what I do this routinely in all my cases, and I've been asking Thomas to do the same in the pediatric patients, and I think Olivia and those, if you guys can do it in pediatrics, it'd be quite interesting. But what we look at is what happens to distensibility during the procedure. And what we find is that this is sort of a schematic of what sort of happens is that distensibility, which is the compliance, reduces as your procedure progresses. And what we found that was most significant was the effect of the hiatal closure versus the fundoplication. So we looked at this actually in 174 patients that we actually flipped. And again, most of our patients end up going home within a day, a lot of times the same day. And all these procedures were done robotically. We did different types of anti-reflux procedure, including Nissens, toupees, links, Hill procedures. And all patients actually we placed biosynthetic mesh that I can talk to you about later on also. And this is sort of what we found. And this is a very busy slide, but I think the one place I want you guys to focus on more is mostly the distensibility. And what we found was most significant for compliance was how you fix the hiatus. So we noticed that post-hiatal hernia repair and reduction of the hernia, you had the most significant impact of on the LES compliance. And again, with augmentation, you had some improvement. You also saw, this is what's called a high pressure zone, which we defined in the study, where we showed how the valve length becomes longer as you do different parts of the procedure. And we noticed that compared to preoperatively, the valve length gets impacted the most just purely based on hiatal hernia closure and with some extra augmentation when you do the wrap. Now, when we looked at the contributions of each part of the procedure to actual compliance, we noticed that 80% of the change in distensibility or compliance comes actually from the hiatal hernia repair and closure, and only about 20% from the type of wrap you do. So the wrap actually significantly caused less change in your compliance with that EGJ than did just repositioning the valve in the right place. And we noticed that it didn't really make a difference if you did a toupee or a Nissen. So this is studies looking at type of fundoplication, and we noticed that the resultant distensibility, which is here on the C graph, is the same for Nissens versus toupee. So it doesn't really matter what kind of wrap you do. They both have the same response. So our emphasis on this paper became more about how you fix the diaphragm and how you support the diaphragm, and less about this kind of wrap you do. So nowadays, I don't actually believe the wrap has actually as much impact as the diaphragmatic closure. And that's why, you know, a lot of the adult surgeons believe that the diaphragmatic augmentation has much more impact than the type of wrap, which is why I think a lot of times when they started doing links procedures, they didn't fix the hiatus, and you got a lot of problems with reflux because the links would go into the chest. And again, with transoral fundoplications, you have a high failure rate because it doesn't address the diaphragm properly. This is something else that we've been looking at, is the tension on the diaphragm as you close. And I think this is important because if you're going to have recurrences, it's because you have too much tension on your primary closure. And this is another group that published their study in surgical endoscopy this year that they actually measured tension, and they noticed that basically if you have a tension of over 4 newtons on your closures, on the crural closure, you're more highly likely to fail on closure, and some other augmentation techniques should be used on those patients to make sure that that closure is done appropriately so you don't get a recurrence. I think this is sort of a kind of a short clip of the evolution of what fundoplication has gone through, and I think I've gone through this cycle and everyone else has. I think if you look at the historically, when hiatal hernias were identified, it was very early on, and then of course suturing was the first technique ever done in 1919, and of course Nissen came up with the anti-reflux procedure, and then of course Collis, a year later was like, no, you need to do lengthening because there's shortened esophaguses, and I used to not believe in this, but I do now. And then a lot of people started doing laparoscopic Nissen fundoplications back in 1991, and then they started augmenting mesh, which became controversial after a while. Again, during this period of time, I was in residency and we didn't really believe in mesh technology and all the data was still coming out. And about 23 publications came out in 2004 saying we should use it. Now, back in 2006, then there was biosynthetic meshes that looked amazing at 6 months. And again, I sort of didn't believe in this stuff, and nor did my mentors, and we kind of pushed away from this. And again, during that period of time, I was doing laparoscopic cases, and I'll tell you why I switched to robotics. And then, of course, all the mesh complications that Oliver talked about and synthetic materials came out. And again, we continue to avoid mesh technology. But even the biologic meshes that were really amazing at the beginning came out with similar recurrences rates at 5 years. I think there's some new mesh technology, maybe not good for kids yet, but I think in adults may be worthwhile looking at. And I think that's what we're going to look at a little bit quickly. Now, when you look at the data that came out in a meta-analysis that was done in 2015, looking at mesh technology and its impact on outcomes, the overall effect was really no difference. So mesh technology had no impact if you look at the data on recurrence. But if you look at the data a little more closely, when they did the meta-analysis, they combined biologic meshes, which is these last two studies, Oschlager and Watson, with actually synthetic meshes that came out in 2002 and 2005. And if you look at the data from those two studies, there was an impact for prosthesis. But the biologic kind of washed it out because as clearly was evidence in Oschlager's study with the long-term follow-up, recurrences occur later out when the mesh dissolves. So if you can get a mesh technology that can sort of have the features of a biologic that dissolves over a longer period, you may have a better outcome at 5 years and cause less reduction. And if you look at all the data of, and this is a nice study that you guys should definitely look at. It's an archive of surgery study in 2004 where they looked at outcomes. Most of the meshes designed in that period were like a kind of a conformation, nearly circumferential, but like more like a kind of a convoluted C-shaped. Again, the studies now, a lot of technology nowadays, and I don't know if you guys use meshes yet, have moved to these biosynthetic meshes. I mean, the two main players have become PAAFIS ST, which is what I use, and BioA, which is not what I use, and I'll tell you why. The biologic meshes that were used before, and I've used them before, dissolve in about 6 months. I actually like this PAAFIS mesh because it degrades into water and carbon dioxide and is not eaten up by the body. BioA, my problem with it is that it dissolves in 6 months also. So if you believe that the Surgisys and the Stratasys that dissolved in 6 months had a poor outcome, I don't understand why this would do any better. PAAFIS actually dissolves over a longer period, which I think is kind of interesting. So this is how PAAFIS works, which is the mesh I use. And this is an abdominal wall reconstruction repair, but basically over 52 months while the mesh is dissolving, it actually improves neurovascularization and tissue ingrowth. And the concept behind the mesh and abdominal wall was that if you can regenerate that strength when the mesh is gone, then that would be really interesting. And that's what we've been looking at in the abdominal, in the hiatal space. Now, again, this is Oschlager's publication in 2011, where basically at 58 months, and these are with large hiatal hernias, the recurrence rate was exactly the same, or very close to using no mesh at all. So definitely the biologic mesh technology is not valid in this period, and I think we need to be looking at something else. Now, I like robotics, and I've done robotics now for about 10 years. I've done probably over 2,000 cases. I think it's pretty slick, and I think for me, and for surgeons that use it, it gives you much more autonomy. You can control all 4 arms, including the camera. And if you're dealing with fellows and medical students, I don't have a camera that's, falling out of field and I can't see things properly. I can basically control the whole case, and I can run them through the case and take over controls when I need to. And we can train residents to do very smooth operations very nicely. This is usually my setup for a robotic room. I do this for all my primary and reoperative cases. I think when you do reoperative cases, they become very complicated because of all the scarring, and you have to be very careful. But we have 2 robotic consoles, the robotic beds, we have trump beds, and we have XI systems, and they're very nice. And this is kind of my confirmation for all my cases. I mean, I do this for everyone. It's 5 ports across. They're all 8mm ports, about 13 centimeters subxiphoid. I use an air shield device, which I don't know if you guys have used, but it's very interesting because you can regulate the amount of CO2 you generate. I usually operate at about 10 millimeters of mercury for most of my cases. I know Dr. Munster talked about capnothoraxes. One of my colleagues out in Portland, Steve DeMeester, he routinely does bilateral pneumothoraxes in all his cases to actually relax the diaphragm. So it's in a more neutral position, especially when you're dealing with large hiatal hernias. So my feeling a lot of times now, if you do get into a capnopneumothorax, is to make the holes really big. I do them bilaterally if I need to. I do not get a chest X-ray in the recovery room, and because it's CO2, it will just resolve. So we never put pigtails and just let them resorb, and most people do fine. The only time people get stressed out is when the hole's really small, and then you get the anesthesiologist freaking out because of tension pneumothoraxes. So make the hole big, but I don't think there's a problem doing it. I don't usually routinely do it. That's why I operate at lower pressure. But if you need to, I don't think it's a problem. This is a video that I just want to show you what the endoflip looks like. This is actually a robotic toupee in a paraesophageal. This is, again, a much different population of what pediatric surgeons will deal with. Usually your patients are not 60-year-olds old with a history of an MI and ulcerative colitis. This is a pretty big type 3 hiatal hernia in this patient. And again, I showed you how we set this up. This is always routine. The nice thing is about no matter what prior surgery most patients have had, the upper abdomen is usually pretty clean. So if you had abdominal surgery for other reasons, the upper abdomen usually is spared. So I think this is pretty nice. Let me, where did that go? Okay, sorry. So yeah, let me let this play out. I may just have to. It's getting stuck. So this is sort of, our approach when we're getting in. So I'm trying to get back to the face. So we're in the abdomen. These are all robotic instruments. These are 3 working arms and the camera. I don't have any accessory ports. This is a vessel sealer. It works beautifully. It cuts and seals at the same time. This is sort of the endoflip at the beginning. You can see at the bottom, you can see that the valve is not very big. And of course, clearly the valve's in the chest, so it's not very compliant. We make the dissection. I go from where it's easiest, I think. The same with redos. The concept I have for reoperative surgery, which I know is difficult, is to go where it's simple and do the easy things first, and again, kind of work your way to the most difficult areas. The chest dissection usually is the most traumatic for most people. The nice thing about robotics is that you do see in 3 dimensions, and you can kind of get into the chest pretty high. I go all the way up. I can get 10 to 15 centimeters into the chest easily with the robotic system for these redos. And unlike the data in pediatrics, the adult data has shown that you do need to do a good mobilization. You definitely want at least 2 to 3 centimeters of esophagus tension-free in the abdominal cavity, and that's sort of what we do. I use V-lock sutures. I don't know if you guys have used this. It's pretty nice to bring the diaphragm together, especially with the big hiatal hernias. And then I use interrupted 3/0 silks. I've been asked before, hey, why don't you just run the V-lock all the way down because it's a braided suture? You can. It doesn't make a difference. There is definitely no. You always have to close the hiatus in adults. You can never leave it open. And you can see that's the end of flip after just the hiatal closure. You can see how the valve has just conformationally changed just by repositioning. So it's amazing how much you can get improved function just by moving the valve back into the abdominal cavity from a large hiatal hernia. This is the mesh. This is a bioresorbable mesh that we're talking about. It's dual layered. I've done different conformation of this mesh. Initially, when I started doing this, I did it as a keyhole. Most recurrences in adults occur between the 12 o'clock position, which is up here, and the 3 o'clock, which is over here. So I think it's important to make sure those areas are covered. And again, with robotics, and there's definitely very slick laparoscopic surgeons around. When you're doing a suturing around this area in this very tight space, the robotics does allow you to get more precision in this area. And we really secure this mesh like we would any other mesh in adults. I try and get nice overlap and make sure the mesh is in the right position. In adults, again, I've mixed my practice now. I used to believe that Nissens were for everyone. I don't believe that nowadays. And so I've tailored the approach based on post-op issues and pre-op issues. That's sort of what our structure looks like now. What you will notice more with adults with Nissens is more bloating than with other procedures. So I try and avoid, if someone already has bloating preoperatively, again, admittedly, it's hard to assess that in a 2-year-old. In a 60-year-old, it's much easier. Then I would do a partial wrap, or I even do sometimes Hill procedures in certain patients which have poor motor function. But in this case, we're doing a toupee, which I think is an adequate procedure. And as you saw from our endoflip data, really is no different as far as compliance with a Nissen procedure. The nice thing about the toupees is that you are less likely to have bloating, and the theory is that you can get less dysphagia, although my dysphagia rate in most of our cases is very low. I do a lot of suturing. Again, this is maybe different in pediatrics, but in adults or maybe teenagers, it may be something worthwhile considering, because there is the most likely reason for recurrence is going to be slippage back into the chest, and avoiding that is, I think, of utmost importance. So I do an anterior pexy and a posterior pexy when feasible. So I think that works out, and that's our sort of final results of what it looked like after the procedure. Good. So let me try and move on to, and then finally, coluses and relaxing incisions. I think they are worthwhile in definitely reoperative surgery. I think a lot of times when you go back in for a second operation, you're going to see a lot more scarring. You have to figure out why they reoccurred, because most of the time they have failure is not because your wrap disrupted, but it's mostly a recurrence. And you have to wonder why that slippage reoccurred if your wrap is intact. And most of the time it's because your length was short. And again, my collis and relaxing incision rates about 5 to 10%. And again, you can see that in a lot of our patients, the length of stay on average is 0.83, which is pretty low because I try and send most people home the same day in all my cases. And as you can see now, there's a kind of a potpourri of different cases, with now a majority ending up being toupees and hills were picking up. I don't want to go through this whole video, but I want to show you sort of briefly what a relaxing incision looks like. I don't know if you've ever done one. So let me just show you. I'm just going to flip to the part which I think is important. This is sort of what a relaxing, geez, this is earlier than I thought. This is how I do a relaxing incision. It's about 1 centimeter medial to the right crus. You can do bilaterals too. You go all the way basically into the pleura. So, and the purpose of it is to allow that right crus and left crus to come together much nicer. Again, these are people with very large hernias, and you're trying to alleviate as much as possible the tension on that closure, so you don't have to have a recurrence without hiatal hernia. So I do these multiple different ways. Nowadays, I just use the vessel sealer for the whole thing. But what it does is, once you're trying to close, you'll see that there's much less tension on that closure. So that crus comes in together much nicer. So the approximation is much easier in that scenario. So the crural closure does get less stressed, and the whole area will basically be approximated much better. But it's not hard to do. You do need to cover the area. When you do bilaterals, you again go on the contralateral side, but it's a very nice technique. The things you have to be careful about, especially in reoperative surgery, is to clearly avoid the IVC, which is going to be medial to that. So you've got to make sure you're in the right plane. And so I think the closure goes pretty nicely. And again, robotics, you know, I think it's great. It does reduce operative time. I think for my reoperative cases, you know, we can do them now in 2 hours, 2.5 hours. And these are very complex cases. And then we measure out the mesh and position the mesh appropriately so it covers both areas. Right now, I'm actually giving instructions to the scrub nurse to know what size mesh we're going to use, and we position that appropriately over the area, similar to what we did before. The only other part of this video I think that's interesting, if I can get to it, is basically to do a collis. Now, I want at least 2 to 3 centimeters of stomach in the abdomen. I place a 50 bougie in the stomach when I do this. And again, these are robotic staplers, and I want to get 2-3 centimeter length extra of esophagus in the abdomen, so we don't have a recurrence. So I use robotic staplers, and I basically run it along the bougie, so we can get extra length in case you need it. I think it's a nice technique. So if you're ever in a situation where you're like, wow, this esophagus is not in the right place, I need a little more length to make sure my wrap is okay and I don't get a reherniation. I think as a foregut surgeon, I think it's important to have a couple tools in your tool shed that can improve lengthening, so to prevent recurrences. But it's I try and take as little stomach as possible. You don't really need to take a lot. But the nice thing is, if you can get a little extra length, your wrap will be in a better place. And then we basically do the wrap in that area, and that goes pretty nicely. For those of you that don't know me, this is not usually the speed I operate at. I sped up this video for convenience, but if you can, I know Oliver operates pretty fast, so this is probably his normal speed. So which is good. But you can do a Nissen pretty nicely using this approach. And again, I do everything else the same way. So I think, in conclusion, I think reflux surgery, definitely in adults, is still evolving and needs to improve. I think it's still unacceptable that we have a high recurrence rate. And I think if you talk to a lot of the gastroenterologists, they still are not convinced that reflux surgery is the way to go in adults. And I think we need better outcomes, which I think involves doing a lot more in the hiatus, maybe incorporating more mesh technology and also incorporating concepts like relaxing incisions and colluses, so we don't have recurrences. I think the other important thing in reoperative surgery is that you redo all the testing. I think it's important that everyone gets a manometry. I do them routinely myself. I do think a Bravo endoscopic assessment is really important, as well as a barium swallow. And you have to have a clear-cut reason why you're reoperating. Is it for recurrence of symptoms? Is it for a volvulus or anything else? But I think they are doable cases. They're more challenging, but being comfortable with a couple different techniques, I think, is important to get better outcomes. Thank you guys for having me, and I'm open to any questions.
Thank you, Raza. It's an excellent presentation, and really we enjoyed your presentation. Up to now, we have one question. How do you determine the size of the future hiatus?
Sorry, what was the question again?
How do you determine the size of the future hiatus?
The height, how tight to make the hiatus? So I make the hiatus pretty tight. I mean, I think when you look at the data in adults, you want to make that wrap so it's hugging the esophagus. We go pretty far in, so you can barely pass an instrument anterior to your closure. So my wraps are pretty, my diaphragmatic closures come in very tight around the esophagus. I actually did a redo of my own patient recently that we actually did everything except I usually routinely close the hiatus first, and then if I'm doing Nissen, I'll do it over 56 bougie, and the bougie actually kind of loosened the diaphragmatic closure, and we had a recurrence right there. So a year out, we actually have to go back and redo it. So there's some colleagues of mine on the West Coast that actually will do the wrap first and then close the hiatus afterwards if they're using a bougie, so they can get as close a closure to tight around the diaphragm at that time.
Okay, thank you. Dr. Gürsu, do you have any questions to Raza? No?
No, thank you.
I think from the audience we have no more questions. We have one question for one of the previous presentations, but I think we're on time. Is it possible to share my screen, please? I want to share my screen. Okay. Can you see my screen?
That's Tutku. That's amazing.
Okay. First of all, I would like to thank all of the participants and all of the faculty members to have this meeting. Very valuable, enjoyable, and also we learned a lot, and it was at least very nice to see everybody here. And I would like to give you some brief information for today. We have total number of participants, as you can see, 243. We have 2 adult GIs, 2 adult surgeons, and 48 pediatric GIs and 154 pediatric surgeons. And at the same time, nearly 14 nurses and other health professions. And when we look at the countries, we have 22 different countries, as you can see. It's not surprising that Turkey is 148 because, but we have a very good, I think so one of the aims of the PAAFIS is in not only the multidisciplinary, but also combining from different countries and different parts of the world. Before finishing, I have to say some special thanks to the Nutricia because they have a very great effort to helping us and to supporting us in they make everything to become real. And I would like to thank all of the people who are working in Nutricia to supporting our meeting. And finally, I would like to thank to Topcon, our organizing company. It was a very hard work, and because we decided to go to perform a web meeting for a short time ago, and they really work out, and I would like to thank their efforts. And I hope we're going to have the next meeting in Turkey in 2021 at the same time in September. And I think we have a large group of people with emails, and we're going to keep you contact and keep you updated about the PAAFIS activities. And I would like to thank again to all our participants and all our faculty members. And I would like to close the meeting. Have a nice day and stay healthy. And I hope we're going to see each other in healthy days.
Great. Thank you so much, Tutku, for all your hard work. This is fantastic. It was a really great meeting. Learned a lot.
Okay.
So how are we going to do this with the executive board meeting?
Now we have to close this meeting and another link.
And another link. Okay, good. We'll do that.
See you. Bye.
Okay.
Thank you, Tutku. Thank you very much. Thank you.
See everyone. Bye. Bye-bye.
See you guys. See you guys.
Bye.
Be safe.
Bye.
Bye.